Hello, welcome. Welcome to Voices of Hope, Infertility as a Path of Learning. Today we have the honor of having Dr. Sergio Tamayo Hussein here. How are you,
Hello,
Doctor?
Susie. Very well, and you? How are you?
Excellent. I'm so happy that you're here in this special event for our patients.
Thank you. Thank you for the invitation. For me, it's also very nice to be with you and to share with what we do here in the INSER clinic.
Wonderful, Doctor. I'm going to talk about you a little bit. He's a doctor, a specialist in gynecology from Universidad de Antioquia. He's also a specialist in human reproduction, teacher in reproductive medicine, part of the group of the professionals at INSER Medellin. Today, he's going to be here with a talk, An Unexpected Storm with the Promise of a Rainbow. What a beautiful name.
Thank you, Susie. It's a bit romantic, but it's very true. And I hope that this is the case for all of the patients, that they can have a happy outcome.
It's like that, Doctor. The doctor is going to talk about infertility. So, Doctor, the floor is yours. I'll see you soon in the end.
Okay, Susie, thank you. Hello, everyone. I'd like to talk a bit about the subject of infertility. As you've seen, I gave it a bit of a romantic title, but it's very true. An unexpected storm with a promise of a rainbow, because really we hope that these couples who go through those feelings of frustration can have that so desired baby and be able to have a family with children. I would like to get directly to the point and define what infertility is. In reality, the OMS, which is the World Health Organization, defines it as a disease or an illness, a condition by which the couple has attempted or sought that pregnancy for over a year without a success, clearly without using birth control. And in my office, where I work on infertility, I see it as a vital crisis. This illness does not threaten our lives. It does not put the lives at risk of any of our patients, but it is significant, it is important, and it generates an emotional toll, which is cyclical. Couples who are struggling with this condition, we know that they face a feeling of hope every month at the beginning of the cycle, and they face failure or a menstrual cycle which tells us this month was not successful, and that's difficult, and I hope that I'm able to address it in a simple manner, in a way that we can understand what we'll be facing in a consultation for fertility, what exams we may have to take, how we can face these conditions, and what we can do later on. And so, as I had said in my office, I see it as a vital crisis. I see patients every day who thought they were healthy, who even started to plan their lives from, in all perspectives, from a financial perspective, traveling, family, around this, and they planned at some point when they would have children. And so they even plan the names of the children, or they plan what their children will do when they're adults. And so having that expectation, that large expectation that this will become a reality, that they'll have children at some point, and then hear that, and to find that it's not as easy as you expected, they face this challenge and they go into shock. For many patients, this can lead to pain, to marital problems, sexual dysfunctions, and have discomfort in telling people about this, as if it were some sort of a stigma or something bad in our lives. Many people, the majority, wish this wasn't the case. They have feelings of anger and injustice. Just yesterday, a patient talked to me about this that I have on the slide. Why can they and I can't? And people who don't want to get pregnant, but I want to and I can't do it. And I have the financial capacity to have a child. I'm not able to. And so you see many feelings, even guilt. People become isolated and everything leads to anxiety, and we can even see depression. So many have these feelings and sometimes blame themselves or feel guilty for having those feelings. And what I'd like to say is that this is more a consequence of the issues of conception, not a cause. We have to have this understanding. And I would like for people to see that visiting a gynecologist or a fertility center as a defeat. We should see it as an alternative to this situation in order to achieve that objective that we want, which is the baby. And so our function here at the clinic is to transform these feelings that you see on the left for these: tranquility, joy, self-love, gratitude, being calm and accepting, and eventually having this happiness of in a family with children. And so I'd like to get more to the point and ask this first question, which is: how much time, how long before consulting should I seek my child naturally? At what point do I have to consult? And for that, I'd like to explain to you a term which is the rate of fertilization, which is the probability of becoming pregnant for each month of attempts. And this is important to take it into account in order to know what I should expect when I start to seek my child, and at what point I should decide to consult because something is not normal. And so the probability of each month having a pregnancy is around 15 to 20% due to different situations, which I'll explain in more detail later on. So as we can see, the probability is not so high. It's not 80, it's not 90, it's not 100% as we might want. Since it's so low, 15 to 20%, we have to give it some time and some opportunity so that it can happen at some point. How long is this time? And so in people under the age of 35, we say we can wait a year before deciding to start studies. In patients older than 35 and under 40, we wait up to 6 months. Patients 40 years old or more, we don't wait at all. And we'll see the importance of this variable of age and why we accelerate this process as we age. And also, depending on whether there are other conditions like problems with ovulation, having a certain medical history where we've seen any illness in your fallopian tubes, if you have any myomes discovered due to some other condition, that you know that you have endometriosis, or that the male has a genetic alteration, and therefore he knows that it's not easy to become pregnant. So we recommend that you seek help as soon as possible. And as we see in the slide, the initial assessment, that first appointment with the doctor, it should be with both family members. That would make it much easier to face this situation in the study and make easier progress. To assess the causes, here I'd like to summarize how a natural pregnancy happens so that you understand why we study each of these things and what we can find in each of them. So since in the office I would explain this, as if we were in the office, I would explain this like you were a preschool child almost, how a pregnancy happens. Normally, the sperm is left in the vagina, in the ejaculate. They have to rise through the cervix, enter the uterus, and they have to go through these orifices that communicate with the fallopian tubes. And they travel the entire path until the end. From the ovary, we have to have expelled one of the eggs of that month. The ovulation happens, and they would enter the tubes through this site. And so this is where we have the sperm fertilizes, and the fertilized egg starts to grow and form this embryo, so that 5 or 6 days later it returns to the uterus in order to see an implantation. As we can see, we basically need 4 factors in order to become pregnant naturally. And I'm going to highlight this a bit more. We have the masculine factor, which is the sperm, the uterus, the tubes and the ovaries. And I have an attachment here, which is endometriosis. There's nothing specific about the human reproductive system, but it's a condition that we always have to take into account and know in some cases if we have to discard this or find it and treat it. So we have to determine what the possible causes of any problem may be, and before that I'll go through a simple explanation of what it could be. And as we can see here, we know that the causes can be of a feminine cause and around 30%, masculine in about 30% as well, and another 30% where there can be masculine or feminine causes. And a remaining 10%, which despite being some basic tests, we might not find a cause. We may see an infertility of unexplained cause without an apparent cause. We can see on the right, these are the female conditions for which we may see in a case of infertility. And as we can see, the majority of them are of tubes or ovulation cause. This is to show that the majority of the conditions are treatable. I'll start to go into some more detail. We'll start to study the 4 factors. Which one would we start with? Basically, the factor of the uterus, where we have the easiest access to. In the first consultation, when we perform the first interview, we have a sonogram on hand. It's the simplest tool, but it's very useful to assess the uterus. And we can see here the idea is to assess the form of the uterus, if there's a growing endometrium, if it's compromised by any obstacles, for the implantation of an embryo. And we see here, I'm going to show you. We have other alternatives to go into more depth in the assessment of the uterus, but they're not done on a routine basis. And I would like to pause here to say that everything in medicine and reproductive medicine is no exception. Everything is individualized. It's not generalized. It's not like a cooking recipe where we can do everything the same. And so not all exams are for all patients, or not all treatments are the same for everyone. So based on the initial interview and this first assessment where we see the uterus, we might determine if there's the need to perform a different kind of imaging or a hysteroscopy, which is a bit more invasive but would allow us to diagnose and treat. This, of course, accompanied by your physician, we can define which of these options we need. Let's go to the factor of the ovaries. In this factor, in the first visit, we can approach this assessment. We can see the anatomical integrity and define that there are no masses. Here we see this graphic. We see the morphology of the ovaries and anything that may show me evidence of something like a tumor. That first image gives us a lot of information. In addition to the anatomy, we need to assess the functioning of these ovaries. And so in this first visit, we go through some hormone assessments which speak to us about how we're working and what is your ovary reserve. And I will emphasize on this subject because I think it's a subject where we still lack a lot of education in society. We don't talk about this in school, and patients in specific have even said to me, I wish I had been told about this sooner so that I could have made a timely decision. And another one of the hormones we request is to look at thyroid function and discard any other kinds of syndromes. But I don't want to go into too much detail on these things because it would take a lot of time. In this, I do want to emphasize a bit more, which is the subject of the ovarian reserve. And I'd like to start by saying that all women, without exception, produce new eggs, which are the ovules and they produce them up to the 5th month of fetal life. And from that moment, while in your mother's uterus, they start to spend those progressively, and they cannot be recovered. Those are not recovered ever. So as time passes, as you see in the graphic, this reservation is reduced, and this translates to in reproduction. As age increases, the reservation drops, and with that, we also see a lower probability of pregnancy. And with this, as we can see, they are completely spent, and we enter menopause in women. I explain this very simply to patients in the office, and although it sounds childish, I know that it's important to do so to clarify this very well. I compare this with the fruit market. Every time we buy all of the fruits in the market, we take them home. Our refrigerator is full, and the fruits look very nice. The banana is yellow, and they're all very good. And with time, we consume these fruits, and the ones that remain at the end of the month, some of them aren't of a very good quality. That's very important, and this is a bit how the ovarian reserve functions. We can quantify, or we can come close to understanding this reservation with an exam, because it's important to highlight that we are humans, we are not robots. So these trends in this curve, although it is true, it does not apply to everyone at the same time. So we must individualize. We must see how each patient stands on this curve, and therefore define what we can do and what we can expect when making decisions for a treatment, and inform and educate patients about what the forecast may be. What are the tools? So basically this first one, which is the count of central follicles. These are these white bags that we see in the ovary sonograms. And ideally we would have more than 5. If you have less, the less you have, then the less you'll have in your ovarian reserve. So this depends, of course, on the doctor that's performing the sonogram, and we can use other tools like the measurement of these hormones, the estradiol. And this one that's been mentioned recently, it's not the time to give numbers, but it's important to assess if it's necessary or not to perform these exams, and with the results, make decisions. Now, why is it important to take into account this subject of the ovarian reserve? Because as we age, the probability of pregnancy decreases. In addition to this, as I said in the example of the fruits, not only does the amount of fruits run out, but also the quality starts to reduce, and that translates in probabilities of chromosome alterations in the baby. And the majority of these are babies who will be aborted due to probabilities of chromosome alterations. And although we see an increase in the probability of having a baby, we see in the curve that increase is minimal. It does double and triple when it's been less than 15-20 years, but it's not like we should make the decision of not becoming pregnant after the age of 40 necessarily. This is very important, and it's something that should be taught in schools, and it should be explained to patients. And we shouldn't end up, when it's too late, realizing that we should have made decisions sooner, because we see that the probabilities decrease as time passes. But it's important that not only do the probabilities reduce naturally, but also in assisted reproduction treatments. As age increases, it skipped a little bit. I'm back. As age increases, we see a reduced probability of pregnancy, even if we go through treatments like in vitro fertilization. Fortunately, we have alternatives like this, like the donation of egg cells. But it would be very good if each patient could be their own donor at some point. That would be very good for them to make early decisions at an adequate time, where their egg cells are of a good quality, so that in the future they could become pregnant with them. So we'll continue and study, and we go to the factor of the fallopian tubes. We have 3 alternatives to study it, and this is the simplest one. And it's important to show what this exam is and how it's done, because many patients arrive and say, I don't want the uncomfortable exam or the painful one. It's important to show the importance of it. And it's a procedure where we introduce a device in the cervix as if we were doing cytology. And through this, we go through a contrast medium, which is liquid. And as this liquid passes, we take images or x-rays. And we can this way see how the uterus is drawn and the fallopian tubes, if they are free and they allow the passage of the liquid, which would be ideal. It should have the space to allow the passing of the sperm. And this is important, and I always recommend that we provide an pain reliever in order to reduce the discomfort that it may cause. We have different alternatives, like what we see in this graphic, in this video. Basically, both are very similar. They're very good for assessing the permeability of the tubes, and to decide which one to use will depend on the availability and the criteria of the doctor that's ordering it, because one may be better to assess certain conditions than the other. But basically, for the factor of the tube, they're very similar. What's the difference in this one? That we do not use x-rays, but as we see in the image, we use a sonogram. So we introduce a imaging device, and as we can see on the image on the right, we can see when the liquid enters. We can see some turbulence here, and we can see when it passes here to the side of the tubes. So this tells me that these tubes are permeable. We have another tool to assess this factor, which is the gold standard, classified as the best, because clearly it can see the tubes directly, and in addition to seeing them directly, we can also assess the pelvic cavity, diagnose if we have endometriosis or not, and in case we do it, or as we can see in the image or the video on the left, if there's any adherence, endometriosis, at that very moment we can enter and treat them, correct them, and thereby improve the reproductive prognostic. And so it's introduced by via the vagina. We see it pass through the tubes. If it does pass, then we see that it is possible to have a natural pregnancy in this case. Finally, we assess the masculine factor, not less important than no less important, although it's last, but it is simpler. Basically, the first approach is a spermogram, a basic spermogram, where what we do is assess the amount of sperm cells, how they move, their form. And for this result to be representative and for us to be able to make decisions with it, we need some basic conditions for this sample. A minimum abstinence of 2 days, maximum 7, no ingestion of drugs or liquor or antibiotics during the month before the sample, time no longer than 1 hour after the reception of the sample, and in a non-toxic sample. It's important to say that for many it could be easy, but for other patients not so much. It's a stressful moment for a man, and we do not always get a successful sample. There are different ways to take the sample, through masturbation or through coitus, with recollection kits that are easy to obtain. And we cannot lose the opportunity of that moment to improve the environment for a healthy pregnancy. So it's a very good moment to do a preconceptual consultation to see if we have all the adequate vaccines, any base conditions, any illness that needs to be controlled, that may put at risk the life of the mother or the child. It's important to try to correct these things and educate in terms of good life habits, and to resolve doubts if there are any. And as I write here, it's important to stimulate the patient so that the assessment happens as a couple. So, what do patients seek when they visit? Basically, the most important thing is to have an adequate focus. Based on this, we can choose the right path in order to get to that goal. And so we try to make this decision without running unnecessary tests. Every patient is unique, and they are their own world. It's not like a cooking recipe that you can give anyone. This is very important. Because we might say, my friend was given this hormone or this exam. Every case is unique, and we guide it to where we believe it can give us results. In this case, we have to identify the causes accurately. We have to perform an adequate diagnosis. And all of these tools will help patients, which will then define what they'll do. And this will help us to save time and to have better success rates. In terms of treatments, speaking of each of them could take an entire congress, but I would like to mention a few things, which is that we as doctors have to make the decision of, or not us, we have to show the best path for our patients. We have to describe the possibilities, the pros and cons, and then after we have all of this, we can make a decision. Now, clearly, we will always be accompanying you, but we try to guide you toward what we believe is best for each case. There are low complexity treatments, and to summarize that, basically low complexity seeks to optimize the natural process. And here we have two: induction of ovulation or intrauterine insemination. Basically, we in one seek to have more ovulation, or an ovulation if you don't ovulate at all, or have a greater exposure this way to pregnancy. And intrauterine insemination, we have an induction of ovulation added to the preparation of sperm cells in the laboratory, and they're introduced to the uterus. But the process of fertilization, the growth of the embryo, all that happens within the body, we have no way to assess that. We can just evaluate if there's a pregnancy or not. And in high complexity, the large difference is that the fertilization process, the growth of the embryo, will happen in the laboratory. Basically, we have from in vitro fertilization to other options. Those are separate subjects. But the point is that it is important to let go of the fear of consulting. You can't assume that you're always going to in vitro fertilization. The vast majority of patients, almost 80%, can have their child using low complexity therapies. Only 20% ever require high complexity treatments from the start, or they have used the other treatments already, and so we have to move on to higher complexity. It is important to say that each patient chooses the treatment. We simply indicate what is adequate, what is best, what we think of each of the alternatives. But we will not force, we will not there's no obligation. It's not like a cancer treatment where chemotherapy is one thing and the patient can't say yes or no. Here, the difference is that there are alternatives. The person can show their references, and this way or their preferences, and we can use this to choose our path. This phrase, I think, is very appropriate for what I'm showing you from Hippocrates, who says, cure sometimes, alleviate often, and console always, accompany always, is what I would say. Obviously with adequate information. And I like this one a lot too. Assisted reproduction is my ally, not my enemy. Because many feel this as, they could feel like it's frustrating to have to use it, but it is an alternative. It is another path to arrive at the same place. And I would like to give you this phrase, which I believe can help you in your path for this search, which is not easy. And honestly, I've been able to see it in many patients. I would like to see it in more. And it is that when they go through all of these obstacles, when they go through these blows and they are able to achieve this goal, believe me, that happiness is greater than all of that. It makes that entire experience into something that just strengthens or increases our happiness and gratitude. So we should have faith and maybe not necessarily stop feeling fear. It's just embracing the promises of God when faced with uncertainty. Anything you need, my doors are open. You can find me through Instagram. You can call me for anything you need. We are beyond willing to accompany you. Thank you very much.
Thank you, doctor. I would like to highlight some parts of your talk. The first thing is the importance to lose the fear of the first time consultation.
Yes, Susie, it's fundamental to let go of fear because there's a social stigma in arriving here. And it's a bit less now. Today there's more freedom. It's easier to talk about this subject, but there's still a lot of taboo around this consultation and treatments. And there's a lack of knowledge in some cases. So it's important to take that first step and start on that journey to arrive that desired dream of starting a family.
Yes. The importance of the integral management, that every single case is very unique. We don't need to compare ourselves.
Yes.
And something very important that you said is that patients in the process, in the reproductive treatment, they have their own voice.
Yes. We don't force anyone to anything or anything against their will, although it is classified as an illness. It doesn't put your life at risk, and so there isn't any emergency service. We explain to the patient the importance of every path, the pros and cons, and as I said, it's about accompanying them and giving them a voice of positivity that they sometimes need, and that embrace, because sometimes we become almost like family with each patient and enjoy every triumph, and we feel every defeat as well and every obstacle as well.
Yes, doctor. Doctor, I want to ask you some final questions that I think can amplify the information you just shared. When do you recommend it's needed to measure the ovaric reservoir?
So in reality, there are some indications. For example, patients older than 35 with a history of ovarian surgery or any history of endometriosis, different conditions that may tell me that the reserve may be diminished, or that in an ultrasound we may see a low count of andral follicles. And so we see that we're generalizing some of the indications, and we have found patients that despite not having this history, when they're stimulated, we find that there isn't a good response. So it's a more common exam nowadays. It's not like if we don't have this history, we can't begin, but there are some conditions that do make it necessary to take these measurements.
One more question. What happens if a man doesn't have sperms in the spermogram?
That's a very important question, Susie. Many arrive at a general physician's office or someone who doesn't have the experience to really assess what should be done from there on, and they may end up castrating that dream of becoming fathers, and they may tell them it's impossible and that's it. And I've seen it, especially even specialists in urology, they tell them that there's nothing that can be done, but that's not always the case. In reality, there's a lot that can be done. We can do in vitro processes. We can assess if there's an absence of the deference conduct. And there are different alternatives. Inseminations with donated sperm. And in some cases, we have to choose adoption.
Very important to consult with a specialist in reproductive medicine to guide the process of the patient. Doctor, when do you recommend to do a laparoscopy? That I heard you mention it.
Well, for many, it could be very aggressive to go for a laparoscopy from the beginning. If there are certain indications, if there are patients that I think there may be an endometriosis, or if I have any suspicion of a condition that can affect the fallopian tubes, any different prior procedures or menstrual pains. In these patients, we may see a condition that could affect the permeability of her fallopian tubes. So there may be some way to correct them, and I don't think it's too aggressive if it's in the right conditions.
Of course, it could be diagnosed and corrective if the case needs it. You talked in the future about being your own donor. What do you mean by that? How can you preserve that ovaric reserve? For example, in a 32-year woman who has limited eggs but is not in her plans to be a mother. What can you do?
That's very important, especially nowadays, where a woman may want to become a mother later on, or maybe they don't know now, but it's not their current priority. They want to go to school, travel, or achieve certain economic goals, but for whatever reason they would like to postpone this, and so that ovarian reserve, it won't stop its consumption, but we can take these eggs and we would do as if it were an in vitro fertilization, and instead of fertilizing, we do what we call vitrification. They become like glass, and when they become like glass, they stop so that they can be used in the future. They are stored at minus 96 degrees Celsius, but after being vitrified, they can be used whenever you'd like. She can arrive 32 years later for a fertilization process through the vitrification, or when she's 32. And then once she's 42, 44 years old, if she hasn't been able to become spontaneously pregnant, then she can begin and she can start a treatment with her own eggs, those ovocytes. And so she's at the age of 44.
That's wonderful. We, as a center, do we manage this technique?
Yes, we do, for over 6 years now. And it's gone very, very well. We have some babies now, product of these treatments. And I have to mention as well, many can do vitrification and then become spontaneously pregnant. It doesn't force them to receive this treatment in the future.
It's important to have that reserve and that possibility.
Like a plan B.
As a plan B, exactly. Doctor, the sentence you used in the end, I loved it. To assume fear as part of the journey and embrace uncertainty. What message do you want to give to the couples, to the people who are contacting us, who are watching your talk, or considering getting pregnant, or have a condition of infertility?
Yes, it's a message I'd like to send, which is that you have to take the leap. You have to overcome the fear of assessing these opportunities and persist. Because if it's something that you truly want, persistence can achieve great things. And I believe in that by the hand of God, great things can be achieved. And this is one of those great things. So often they give up on their path or for whatever reason, but really to persisting and continuing will lead you to have that desired baby. And that's what gives us as doctors the peace of mind and the happiness of achieving it, because more than us doing it, it's accompanying you in that process and watching it happen.
Wonderful, doctor. Well, very big hug to you. Thank you for your time, for your kindness, for your dedication, and for always thinking about your patients. A very compassive hug. Until the next time. See you soon.
Thank you very much, and a hug to you.